Everyone, welcome to today's presentation on breast health awareness. Throughout the presentation, please feel free to leave any comments or questions down in the chat function below as we go along, and we'll leave a bit of time for Q&A at the end of the presentation to address any and all questions, and then we'll open the floor for discussion and any input from the audience. This presentation is being recorded and will be posted onto our YouTube channel. So if you want to send it along to any family members or friends that may have missed it, we'll give you the chance to do so. And before getting started, I'd just like to introduce our incredible presenter for the day, Dr. Lisa Newman. She's going to be discussing screening, early detection, and treatment for breast cancer. Dr. Newman is a surgical oncologist. She has extensive clinical and research experience dedicated to breast cancer management. She's currently the chief of the section of breast surgery at New York Presbyterian Weill Cornell Medical Center, and she leads the multidisciplinary breast oncology programs at the David H. Koch Center, which provides patients with the most comprehensive care. A great portion of her research has focused extensively on disparities in breast cancer risk, and she will be touching on some of these findings during her presentation today. She maintains a very, very active community service record, and she currently serves as the Chief National Medical Advisor for the Sisters Network, which is a national African-American breast cancer survivor support organization. So once again, thank you so much for joining us today, Dr. Newman. I'm going to pass it along to you to get started.
Thanks so much for such a gracious introduction, Allegra. So yes, I am very honored to have this opportunity to talk to all of you, and I appreciate the invitation to join you. I will spend the next few minutes talking about breast health awareness in the 21st century. And I know October is Breast Cancer Awareness Month, which motivates a lot of groups to invite these types of conversations to be initiated. But hopefully I'll be sharing some messages with all of you guys that you will feel free to bear in mind throughout the year and to share with the community, because there is a lot more that we need to do in terms of informing women and men about ways that they can effectively protect themselves from the morbidity of breast cancer. Now, the good news is that because breast cancer is such a common disease, especially here in the United States, we have developed extremely effective ways of controlling it so that it is treated, caught at an early stage, and so that we can prevent it from being a life-threatening problem. And those improvements in outcomes are demonstrated on this graphic, showing how death rates from breast cancer have indeed declined over the last 30 years, largely because of improvements that we've made with screening, allowing us to find a cancer before it causes any symptoms, and improvements in treatment so that they are taken care of appropriately. Now, it's very common, especially in October, for women to ask the question, well, am I at higher risk of getting breast cancer compared to another woman? And we do indeed know of several risk factors that identify women at higher risk. And some of these risk factors are shown on this slide. For all women, as we get older, our likelihood of being diagnosed with breast cancer increases. We do see breast cancer in young women, but the likelihood of getting a breast cancer increases as we get older. Family history plays a role. And if you have relatives with breast cancer, ovarian cancer, other types of cancer, that might indicate a hereditary predisposition for developing breast cancer. There are certain benign breast biopsy features that might indicate that you are at higher risk of getting breast cancer in the future. And so if you've had a breast biopsy and you were told that the results were favorable and did not show cancer, that's definitely good news. But please make sure that you know the details of that biopsy result, because some benign fibrocystic breast biopsies do indicate that your breast tissue is overactive, and this overactive breast tissue is more likely to develop breast cancer changes in the future. So you want to know about that type of a biopsy report so that you can take better care of yourself with strengthened breast vigilance. History of a breast therapeutic radiation exposure. And in the past, Patients with Hodgkin's lymphoma were very commonly treated with radiation that covered the chest wall. And if they received that radiation during adolescence or early adult life, that radiation could increase the subsequent risk of breast cancer development. There are lifestyle patterns that also increase breast cancer risk. Obesity, especially for postmenopausal women, is a breast cancer risk factor. Taking hormone replacement therapy postmenopausally increases breast cancer risk, and excessive alcohol intake increases breast cancer risk. So it's all about moderation. There are some cardiovascular benefits of small quantities of alcoholic beverage ingestion, but please do not go overboard. Excessive alcohol intake, especially on a daily basis, increases breast cancer risk. We will talk about mammographic breast density, but this is also a pattern demonstrating that a woman is at higher risk of getting breast cancer in the future. In terms of predicting women that are at higher likelihood of hereditary breast cancer, we look at a personal cancer history. And women that are diagnosed with breast cancer at very young ages, women diagnosed with ovarian cancer, these can be markers that you have some hereditary or familial predisposition for cancer. Look at the family history, and when we evaluate family history, we have to look at both the mother's side and the father's side of the family. We look at the number of relatives diagnosed with cancer and the types of cancers, the ages at which those relatives were diagnosed with cancer. The presence of breast and ovarian cancer in the family is a red flag, as well as other types of cancers. And if there is a man in the family with breast cancer, that's actually a very strong red flag that there might be some hereditary predisposition for cancer. Ashkenazi Jewish individuals also have a higher likelihood of carrying one of the hereditary breast cancer gene mutations. And if we see any features that indicate a likelihood of having hereditary breast cancer, we can test for some of those genetic changes by getting either a saliva specimen or a blood specimen. And then these patients are referred to have genetic counseling so that they understand all the pros and cons of pursuing genetic testing. But that genetic test result can be informative in helping the patient decide how to be screened for cancer in the future. Despite knowing a lot about these various breast cancer risk factors, it remains true that at least 3/4 of the women diagnosed with breast cancer have none of these identifiable risk factors. And so we do all need to be aware of ways that we can protect ourselves from breast cancer through screening and early detection. We continue to ask about breast cancer risk factors in the clinic because when we do identify women that are at higher risk, we want to make sure that if necessary, that they undergo genetic counseling and genetic testing. We might want to offer them supplemental screening, such as additional screening on top of regular mammograms. We might want to offer them prevention strategies, and some women will be referred to take special pills that can lower their risk of getting breast cancer. Some women may even pursue the most aggressive strategy of prophylactic or preventative mastectomy surgery to lower their breast cancer risk. Screening for breast cancer means that we are trying to find a breast cancer before it spontaneously causes any symptoms in the breast. And we can screen for breast cancer by breast health awareness and just doing a self-examination to detect a breast lump before it becomes obvious in the breast. We can detect a breast cancer early by having our healthcare provider perform a professional clinical breast examination on a regular basis. The modality of screening that has generated the most data showing its effectiveness is screening mammography. Now, screening mammography guidelines are intended for women with a normal breast exam because screening mammography is intended to look for a breast cancer that is not causing any symptoms in the breast. If a woman does develop symptoms in the breast, she needs to embark upon a diagnostic evaluation, which might mean repeat mammogram and or other imaging, and it might mean a biopsy to further evaluate that breast symptom. Now, all of you in the audience are probably aware of the fact that there is indeed quite a bit of controversy currently regarding the optimal screening mammography schedule for average risk American women. And when I say average risk American women, I'm referring to women that do not have any of the risk factors that we talked about previously. So I'm talking about women that do not have evidence of hereditary predisposition for breast cancer. And I'm talking about women that do not have any breast biopsies from the past showing that they are at increased risk for getting breast cancer. For average risk American women, some people continue recommending that women get mammograms every year starting at age 40. Other organizations say that women should wait until they reach age 45 or even age 50. The strongest data in terms of mammography saving lives is associated with women getting yearly mammograms starting at age 40. And that's why all of the academic and professional societies shown on this slide advocate in favor of women at a minimum having access to screening mammography beginning at age 40. Some of them may support saying that a woman has to get that mammogram by age 45 or even 50, but they all say that a woman should at least have access to a mammogram beginning at age 40, and she should discuss screening mammography at age 40 with her healthcare provider. Now, many of my colleagues and the National Comprehensive Cancer Network, we all very strongly advocate in favor of yearly mammograms, annual mammograms, beginning at age 40. And as shown by this graphic, when we started instituting screening mammography at age 40 several decades ago, that actually corresponded when we started reducing the mortality rates from breast cancer because of the ability of mammography to detect cancers earlier and to save more lives. Now with COVID, we've all had to pivot in support of social distancing policies so that we can mitigate the effects of the pandemic. And this applies to our mammography screening practices as well. During the COVID hiatus, when we had to basically shut down all of our elective medical checkups, including our clinics and our screening mammography units back in the spring and early summer of 2020, many women had to delay getting their screening mammograms performed. We have, however, learned how to implement mammography in a safe way now that that COVID hiatus has ended. And we do want women to get back into the swing of things with regard to their usual healthcare, including their mammography screening practices. In the post-COVID hiatus era, our screening mammography units utilize no-touch techniques to minimize the possibility of spreading the viral contagions. We screen patients for any symptoms and travel history prior to arriving in the mammography unit. After arrival, temperature checks are taken and additional screening questions are asked. And we adhere to social distancing policies on site. We try to stagger arrivals so that there are fewer people in the facility at any one time. And we do minimize number of visitors and number of people in the waiting area, again, in adherence to social distancing policies. So a standard screening mammography is performed as shown on this slide. We basically rely upon two views of each breast, one view being the profile view, or what we call the MLO view, the other view being what we call the CC or craniocaudal view, where the breast is being compressed and the mammo camera is taking pictures from the top down. And with these two views, we can get an idea of whether any abnormality in the breast is located in a particular quadrant of the breast. 3D tomosynthesis is something that many of you may have heard about. And tomosynthesis is a version of mammography, but with 3D tomosynthesis, the camera is basically taking a picture of the breast tissue in a rotational fashion. So it allows us to get very nice, thin sliced images of the breast going all the way around. And it cuts back on some of the recall rates. Some of you may have had mammograms, the standard 2-view mammograms in the past, where you were told after the fact that there was something on the mammogram that the radiologist wanted to get a better look at. And so they would bring you back in to do additional mammogram views with even more compression, unfortunately, and then magnification. And those are what we call diagnostic views. Well, with this 3D tomosynthesis mammography, we can do fewer recalls because we get better, more precise pictures of the breast right off the bat. It doesn't take away those recall rates completely. Some women do still have to come back in for additional diagnostic imaging, but it does reduce the recall rates. And most importantly, it improves our ability to detect breast cancer earlier. Some breast cancers show up as a mass, a spiculated lesion in the breast, as shown here. When we see a new lump on a woman's mammogram, the radiologist will characterize that lump in terms of how nicely rounded or oval it appears versus having irregular or what we call spiculated margins. And the irregularity of the borders will go along with a more worrisome appearing lump in the breast. Some breast cancers can be more difficult to see than others. It's very common for many women to have a lot of density or thickness in the breast. Thicker breast tissue will look relatively whitish on the mammogram. Fatty replaced breast tissue will look like a very dark shade of gray. Cancer-associated findings on a mammogram are whitish, just like dense tissue, and so sometimes a cancer-associated white density on the mammogram can be camouflaged by the surrounding density in a mammogram. So the radiologist really does have to use their trained eye and expertise to make sure that they are getting the best pictures possible in order to identify a cancer that might be hiding in the breast. The radiologist will also look for something called microcalcifications on the mammogram. Microcalcifications on a mammogram will often look like little grains of salt sprinkled on the mammogram. Again, thanks to the expertise of the trained eye of our breast radiologists, they are very good at being able to distinguish the cancerous appearing pattern of these microcalcifications from the benign causes of microcalcifications. Now, important for everybody to understand that the presence of these calcifications, this calcium on the mammogram, is not related to calcium in your diet. Many microcalcifications are caused by benign findings like benign fibrocystic changes. Sometimes the calcifications are just present in the skin. Sometimes calcifications are present in blood vessels that are totally benign. But if the microcalcifications have a worrisome, suspicious appearance, raising concern for the presence of a cancer, then the radiologist will recommend a biopsy to confirm what is going on in that breast tissue. As I alluded to previously, breast density is an important feature on screening mammograms. The breast tissue of young women is often quite dense in appearance. One of the things that radiologists have learned in the more recent years is that extensive or extremely dense breast tissue is often a risk factor for higher likelihood of getting breast cancer in the future. But density on in the breast as a risk factor for breast cancer is something that the radiologist determines based upon the mammogram. If you have a breast exam by your healthcare provider and they mention that you have dense or very thick fibrocystic breast, that does not necessarily correlate with mammographic density. And it's mammographic density that is the actual risk factor for future breast cancer development. If the radiology does make a determination that you have a very dense breast, then they will talk to you about supplemental ways that you can evaluate your breast, such as breast ultrasound or sometimes even breast MRI, to get better images of your breast in addition to the mammographic evaluation. Breast ultrasound is a very useful adjunct to screening mammography, and breast ultrasound helps the radiologist in evaluating some of the shadows that can show up on a mammogram. The radiologist will often use ultrasound to distinguish a cyst, which is encapsulated fluid in the breast, from a clump of solid encapsulated tissue in the breast. Often, the appearance of a lump on the breast by ultrasound will give the radiologist a very strong clue regarding whether a given lump in the breast is cancerous or not, and will guide the radiologist in making a recommendation for whether or not a biopsy needs to be performed. Breast MRI is yet another way of evaluating breast tissue. Breast MRI is a very, very sensitive way of taking photographs of the breast. Breast MRI, similar to ultrasound, does not involve any radiation exposure. Mammography does involve radiation exposure. We use breast MRI to monitor the breast tissue of high-risk women, such as women that have hereditary predisposition for breast cancer. We also use MRI to evaluate women that have silicone implants in place. And in these women, sometimes the MRI can be useful in determining whether or not there's any silicone rupture. For women that have hereditary predisposition for breast cancer, the MRI is done in conjunction with mammogram. It does not replace the mammogram for screening, because there are some early forms of breast cancer that are better seen on the mammogram compared to the MRI, such as those microcalcifications that we referred to previously. So as we've been mentioning, early detection of breast cancers through screening does indeed save lives because of its effectiveness in catching cancers of the breast at a small size, but there are other downstream benefits of early detection and screening. If a cancer is caught at a small size, it is more likely that we can offer the patient breast-saving surgery and avoid a mastectomy. If a cancer is caught early and the woman does need to go through mastectomy surgery, she's a better candidate for a successful breast reconstruction to be performed by the plastic surgeon at the same time that the mastectomy is being performed. When we catch a breast cancer early, the patient is less likely to need some of the more difficult medical treatments for that breast cancer, such as chemotherapy or such as extensive lymph node or axillary surgery for that cancer. So many benefits of early detection for breast cancer. Extremely important to emphasize, however, is the fact that none of our breast imaging modalities, mammogram, ultrasound, MRI, none of them is a perfect way of evaluating a breast. And if a woman develops a danger sign of breast cancer, she needs to seek prompt medical attention. Some of the danger signs of breast cancer are listed on this slide. A new lump in the breast, new lump in the underarm area, a bloody nipple discharge, changes in the skin of the breast, such as redness or inflammation, swelling in the skin of the breast, eczema or dermatitis types of changes in the skin of the nipple areolar region. All of these symptoms, any of these symptoms, should prompt you to talk to your healthcare provider to get an evaluation. Now, we don't want you to panic if you develop any of those symptoms, because all of those symptoms can also have completely benign causes, but you do need to get that symptom evaluated and taken care of. If you do not feel that you are getting adequate responses from your healthcare provider regarding these new symptoms, please continue to ask questions or even go ahead and get another opinion. I do also want to mention that there are things that we can do with our lifestyle to lower breast cancer risk. Nothing is perfect, and there isn't any magic lifestyle that will guarantee against getting a breast cancer, but some strategies can lower breast cancer risk. For premenopausal women, if you go through a pregnancy, lactating, nursing the babies is one way to lower breast cancer risk. Following a healthy, balanced diet with lots of fresh fruits and vegetables, Avoiding obesity. This is also a good way to reduce breast cancer risk. Exercising regularly and avoiding a sedentary lifestyle. And also, as we mentioned previously, minimizing alcohol intake is also effective at lowering breast cancer risk. If a change does develop on breast exam, or if there is an abnormal, worrisome finding on the breast imaging, a biopsy of the breast is the only way to confirm whether or not a cancer is present. And biopsy confirmation of a breast cancer diagnosis is necessary before any treatment can be initiated. Any breast biopsy means that we are somehow extracting breast tissue that can then be analyzed under the microscope by a medical specialist called a pathologist. Some biopsies of the breast will be in the form of a needle biopsy. Other biopsies are in the form of surgery, where the woman has an operation to make an incision on the breast and to remove a piece of breast tissue. Some biopsies are what we call punch biopsies, where we use a circular scalpel to remove a little piece of skin from the breast. We prefer, whenever feasible, to establish a diagnosis of breast cancer with a needle biopsy as the first step, because then the woman can move on to her planning of definitive treatment for her cancer more efficiently. If, however, the needle biopsy strategy is ineffective at giving confirmation regarding the underlying diagnosis, sometimes we will be forced to tell a woman that she does still need to have a surgical procedure in order to determine whether or not a breast cancer is present. Once a breast cancer has been diagnosed, the basic principles of developing that treatment plan are as shown here. And here I'm talking about the 3 principles associated with coming up with a treatment plan for an invasive or a full-blown cancer. In situ or precancerous conditions usually do require surgery as well, but often the surgical plan for precancerous conditions, or something that we call DCIS, ductal carcinoma in situ, the treatment plan for those precancerous conditions can be streamlined and modified. For invasive breast cancers, we need to make sure that the cancerous lump that led to the biopsy and the diagnosis has been removed. And this is why some surgery will generally be necessary for nearly all breast cancer patients. And then we will also usually need to treat the microscopic cancer cells that are usually hiding in the normal appearing breast tissue surrounding the cancerous area that led to the biopsy and the diagnosis. We can accomplish those first 2 principles by either doing a mastectomy, which will usually be accompanied by breast reconstruction performed by the plastic surgeon, or we can address these 2 principles with breast-saving surgery, where we perform a lumpectomy, and then we treat the microscopic cancer cells hiding in the normal appearing breast tissue with breast radiation therapy. And breast radiation is very targeted X-ray beam treatments that go directly at the breast tissue itself, and these radiation treatments are very good at killing those microscopic cancer cells. Often women with invasive breast cancer will need to have the lymph nodes, the glands, and the underarm surgically checked with a small operation that we call a sentinel lymph node biopsy, because this information regarding the lymph nodes helps us to stage the cancer, or to basically get additional information regarding the aggressiveness of the cancer. And that information can help us to decide whether or not a woman needs chemotherapy in addition to these surgical treatments. And chemotherapy, when it is necessary, is important in helping to prevent metastatic breast cancer. Many patients will need medical treatments in the form of special cancer-fighting pills, which can also prevent metastatic breast cancer. So now I'd like to turn the conversation to some of the work that I've had the honor of being involved in regarding breast cancer disparity and striving to achieve breast health equity in the United States and around the world. And this conversation is very important here in New York because we do see a great deal of disparities in the breast cancer burden related to having such a beautiful and robustly diverse population here in metropolitan New York, as demonstrated by the distribution shown on these bar graphics of the communities in all 5 of the New York boroughs. Our breast program for Weill Cornell Medicine and New York Presbyterian Hospital Network involves sites in Manhattan, Brooklyn, and in Queens. And the diverse population of these 3 campuses is a patient population that is really nicely aligned with some of the international breast cancer research that we've been conducting, where we've been looking at the breast cancer burden of women residing on different continents of the world. Most of our efforts thus far being in women residing on the continent of Africa, but we do have partners in South America, Central America, and we are actively engaging research partners in yet additional parts of the world. Now, we've been talking repeatedly about the benefits of breast cancer early detection, and these bar graphs are demonstrating survival rates from breast cancer in women with different stages of breast cancer at diagnosis, but showing specifically the survival rates for breast cancer among women with different racial ethnic backgrounds. And what you see here is that women with the earliest stage breast cancer, stage 1, stage 2 breast cancer, and even to some extent stage 3 breast cancer, these women, regardless of racial ethnic background, have the very best outcomes through early detection of their disease. The stage 1 breast cancer patients indicate the smallest size tumors where there is no involvement of the lymph nodes, the glands, and the underarm. And for these women, again, regardless of racial ethnic identity, they have excellent outcomes as long as they receive appropriate treatment. For African American women, however, we do see incrementally slightly lower breast cancer survival rates within each stage at diagnosis. Now, African Americans have higher poverty rates compared to women of other racial ethnic backgrounds. There are higher rates of lacking insurance or being underinsured, higher rates of unemployment in the African American community. So all of these socioeconomic disadvantages will definitely have consequences in ability to detect breast cancer early with screening, mammography, and other imaging modalities. And this leads to the more advanced stage distribution that we see for breast cancer in African American women. This more advanced stage distribution will ultimately result, unfortunately, in the higher death rates that we see from breast cancer in the African American community. However, there are other characteristics that describe the breast cancer burden of African Americans that really cannot be easily ascribed to socioeconomics. For example, African American women compared to white American women are more likely to be diagnosed with breast cancer at younger ages. And more than a third of African American breast cancer patients are diagnosed younger than age 50 years, compared to only 1/5 of white American breast cancer patients being diagnosed in this premenopausal age range. Black African American women are more likely to have the biologically aggressive patterns of breast cancer, such as breast cancers that we call high grade, estrogen receptor negative, hormone receptor negative, triple negative breast cancer, and a higher incidence of what we call primary inflammatory breast cancer. These are all features of biologically more aggressive disease, and they are all more common in Black African American women compared to white American women. There is also a very poorly understood higher incidence of male breast cancer in the African American community. And so because of all of these characteristics, we really do need to be looking at tumor biology and genetics, and how these tumor biology and genetics factors also play a role in explaining some of the breast cancer disparities that have been documented. Triple negative breast cancer is a cancer that, as I referred to in the previous slide, is twice as common in Black African American women compared to white American women. and it is a biologically more aggressive pattern of breast cancer. For any breast cancer, we always look at three important markers: the estrogen receptor, the progesterone receptor, and the HER2/neu marker. These markers that we evaluate on breast biopsy material give us a lot of clues regarding the nature, the basic biology of that cancer. And they are also important in defining some of the medical treatments that a woman will need for her cancer, such as whether she will need special hormonally active cancer-fighting pills, or determining if she needs anti-HER2 treatments, or determining if she needs chemotherapy for her breast cancer. The triple-negative breast cancers are most likely to require chemotherapy as the medical treatment that we rely upon in order to prevent metastatic damage from that breast cancer. Now, there's been an interesting phenomenon that has occurred in recent years. The incidence rates of breast cancer have actually been rising among African American women compared to white American women. And in the past, incidence rates of breast cancer were lower for Black women compared to white women. But now the incidence rates of breast cancer have equalized for Black and white women. These rising incidence rates of breast cancer among Black women, coupled with the higher risk of the biologically aggressive triple-negative breast cancer in Black women, has resulted in a widening of the mortality gap. And today, breast cancer mortality rates are 40% higher in the Black African American community compared to the white American community of adult women. Now, our group, the International Center for the Study of Breast Cancer Subtypes, for several years has been studying the breast cancer burden of women on the continent of Africa, because we have been trying to get some clues regarding whether or not there are actual hereditary genetic patterns associated with African ancestry that predisposes African American women to this risk of getting triple-negative breast cancer. And so we've been very enthusiastic about the prospects for this type of international research to teach us more about the causes of breast cancer disparities here in the United States, but also to teach us more about the causes of triple-negative breast cancer overall, because this is a particular pattern of breast cancer that we really don't know a whole lot about in terms of what causes it to occur. In summary, this is what we've seen with regard to frequency of triple-negative breast cancer. In our work with Ghana, which is located on the western sub-Saharan coast of Africa, the breast cancer patients that we have evaluated have a very high frequency of triple-negative breast cancer, and about half of the Ghanaian breast cancer patients that we've seen have triple-negative breast cancers. In contrast, where we work in Addis Ababa, Ethiopia, which is located on the east coast of Africa, only about 15% of the breast cancer patients that we've cared for have triple-negative breast cancer. The frequency of triple-negative breast cancer among African American women is intermediate between what we see in Ghanaian women and what we see in white American women. So we have coined the term of oncologic anthropology to try to explain these patterns of triple-negative breast cancer. The transatlantic slave trade from several hundred years ago actually brought the ancestors of contemporary Western sub-Saharan Africans, including the ancestors of contemporary Ghanaians, across the Atlantic Ocean to serve as slaves in the colonies. And so as contemporary African Americans, we have quite a bit of shared ancestry with contemporary Ghanaians, but we don't have quite so much shared ancestry with contemporary Ethiopians, because the slave trade from East Africa brought the ancestors of contemporary Ethiopians further eastward to the Mideast and to Asia. And so what we've been honing in on is the hereditary aspects, specifically of Western sub-Saharan African ancestry, as predisposing for likelihood of getting triple-negative breast cancer. Now, many of you may have heard of things called ancestry informative markers, which are genetic patterns that we can look for to quantify our ancestral heritage. And with commercially available products such as 23andMe, other products, these ancestry informative markers can be evaluated to give us some idea of where our ancestors came from. This slide comes from the work conducted by the brilliant anthropologist, Dr. Sarah Tishkoff. And what Dr. Tishkoff is showing in this slide is that markers of ancestral background, these genetic markers, are not necessarily genetic markers that popped up randomly. Many of these genetic ancestry informative markers are signs of genetic patterns that developed as a consequence of our ancestors having to survive various environmental threats, such as related to surviving in different climates, different altitudes, or surviving different infectious diseases. And therefore they represent actually evolutionary selection pressure on the human genome. Well, several generations later, you can still see some of these ancestry informative markers with populations that reside in different parts of the world. There is a particular genetic marker called Duffy null, which is specifically linked to Western Sub-Saharan African ancestry. And our research team with the International Center for the Study of Breast Cancer Subtypes, led by our brilliant researcher, geneticist, Dr. Melissa Davis, we've actually been studying the Duffy null variant as a marker of Western Sub-Saharan African ancestry that appears to be linked to the risk of getting triple negative breast cancer. And we see this Duffy null variant expressed to different degrees among women who have Western Sub-Saharan African ancestry in different parts of the world. And we're very excited to be learning about how the Duffy null marker impacts on risk of triple negative breast cancer. The reason why the Duffy null variant is so common in women with Western Sub-Saharan African ancestry is because the Duffy null marker confers some resistance to the development of malaria. And malaria became endemic, became very common in Western Sub-Saharan Africa many thousands of years ago. And because malaria is such a deadly disease, there are actually several genetic variants that can be seen in people with Western Sub-Saharan African ancestry that were acquired out of a need to develop some resistance to this deadly disease. The Duffy null variant is one of them, and the Duffy null variant appears to have other consequences related to cancer risk. So with the last couple of minutes that I have left before we have some questions, I just want to talk a little bit about the impact of COVID-19 on breast health awareness and disparities. The NCI, the NIH has been projecting that because of the impact of the COVID-19 pandemic and shutdown, causing us to have to delay breast cancer and colorectal cancer screening, and the shutdown of a lot of our cancer research laboratories, which has hampered our research into better cancer treatments, that we're going to see consequences in the future breast cancer burden of Americans. And they estimate that in the next 10 years, we are likely to see an excess 10,000 deaths from breast and colorectal cancer because of the COVID pandemic. As we all know, the COVID-related recession has been disproportionately severe on communities of color and among Black African Americans and Hispanic Latinx communities. Recovery from the COVID recession has been much more sluggish, and this is probably going to have an impact disproportionately in terms of the breast cancer burden, and it may well aggravate breast cancer disparities among communities of color. But I do believe that if we all work collaboratively, there are ways that we can mitigate the likelihood that the excess deaths from cancer in the next 10 years, that it will be felt disproportionately among communities of color. We have to work hard to make sure that expanded Medicaid opportunities are available to those that have lost employment and employment-based insurance as a consequence of the COVID recession. We have to support our safety net public hospitals that have been disproportionately devastated by the costs of COVID care, because these safety net hospitals also deliver a lot of our cancer screening and cancer treatment to communities of color. We have to support our advocacy and philanthropic groups that have relied upon a lot of public large gatherings in order to raise funds for their community outreach efforts with regard to cancer. And these public fundraising efforts have been cut down because of social distancing. So we have to support our partners in philanthropy. We also have to address the digital divide, which is more than a rural-urban phenomenon and disparity. Even within metropolitan areas, it's been demonstrated that African-American households are less likely to have high-speed broadband internet access compared to white American households. And now post-COVID, we are that much more reliant upon the internet, not only for employment and education, but also for healthcare. So we definitely need to work on getting more widely available high-speed internet to all of our communities. And so in closing, I just have a couple of questions and concerns that I'll answer that often come up. Does breast pain indicate that I have or that I don't have cancer? No. If you do develop new breast pain, especially if it's associated with one of the other danger signs that I mentioned, please do talk to your healthcare provider, but pain in and of itself is not an indicator of a cancer, nor does it tell you that a new lump in the breast is not necessarily cancer. Should I get mammograms more frequently if I have a family history of breast cancer? Possibly. If you do have relatives diagnosed with breast cancer at young ages, you may need to get your mammogram starting at a younger age. Does exposure to air make a tumor spread? Absolutely not. Doing a biopsy of a lump in the breast does not cause that cancer to spread. Cancers will, however, spread if the diagnosis and the treatment is delayed excessively. Does stress cause cancer? There possibly is a relationship between the chemicals that circulate in response to stress and the chemicals that can be associated with cancer. Unfortunately, we haven't become sophisticated enough in the research world to be able to manipulate stress or to completely decrease stress from our lives. And so this is a topic of ongoing research. Can I avoid breast cancer with a special diet? Best advice is to follow a healthy, balanced diet with lots of fresh fruits and vegetables. Is there any way to prevent breast cancer? Maintain a healthy weight, healthy, balanced diet, lactate, nurse the babies if you're premenopausal and go through pregnancy. Some women at very high risk may want to consider special medication to reduce breast cancer risk, or they may even want to consider prevention mastectomy surgery. Last question that often comes up, do bras cause breast cancer? Absolutely not. Please do wear a brassiere that you are comfortable wearing and that gives you good support. And I will close there, but I again thank everybody for their attendance and their time and attention today.
Thank you so much, Dr. Newman, and thank you for preemptively answering a lot of those questions, because I think that was quite a few of them as well, and I was about to ask. And I thought it was very informative about the different ancestral patterns of inheritance as well.
Thanks. Thanks, Allegra.
I just had a question about that part. So given the ethnic differences and types of breast cancer, do you have specific recommendations for African-American patients who may have ancestry in Ghana, or is it the same as just getting regular mammograms frequently?
Yeah, that's a great question, Allegra. And there are some clinical studies underway trying to determine whether or not we can use specific ancestry informative markers to guide women better regarding when and how frequently they need to do mammographic screening. So hopefully the marker that we've been looking at, Duffy null, will be incorporated into some of these studies. Right now, the best advice is for all women to start their mammograms at age 40 and to continue those mammograms every year. But if you get a danger sign of breast cancer, I don't care if you had a mammogram last week, please do get that new breast symptom checked out.
Yes, thank you.
Thank you so much, Dr. Newman. I enjoyed the presentation. And this seemed fresh and a little different from the other two that I saw. So thank you so much.
I have a
Thank you so
question,
much, Dr.
Dr.
Phillips.
Oh, okay, I think we have a question. Go ahead.
Hi.
I have a question. My question is, I have gone to so many different health presentations, including, breast cancer and colon cancer and all kind of cancers and everything. I have been hearing the same word, disparities, among, I am very concerned about that word. Why is there a disparity among, why should there be disparity?
Yeah, well, there shouldn't be. Thank you for making that point. And striving for health equity, especially in the cancer world, is absolutely something that has to be front and center on our public health radar. And these inequities exist for a lot of different reasons. Now, obviously, the research that I've been involved in looks specifically at the possibility that there are some genetic features that can be contributing to the biologically aggressive breast cancers that are seen more commonly in African-American women. But these genetic features are not the complete explanation for breast cancer disparities. And step one involves getting rid of the access barriers to healthcare that we see among communities of color disproportionately. And so the lack of insurance, the delays in a cancer diagnosis, resulting in a more advanced stage distribution for a whole variety of cancers, not just breast cancer in communities of color. These are probably the biggest reasons for why we see higher death rates from a whole series of different cancers among communities of color compared to white Americans. So
but there is insurance I see there, especially in New York, and there is an insurance that folks that are not having an insurance could get, and if that insurance is given to that person, why should there be a disparity if there's insurance that is given by the state, and people are, especially minorities do need insurance? So why should there be a disparity? Why shouldn't that insurance be available to everyone who would need treatment and prevent this disparity?
Yeah, so I totally support everything that you've said, and you are correct. Unfortunately, however, the reality is that insurance doesn't completely fix the problem. And systemic racism is very real in public health, and it has a very real, very tragic impact on cancer outcomes, and it affects cancer disparities. It contributes to cancer disparities. People that are underinsured, people that have public insurance, unfortunately, do not necessarily get the same treatments delivered as patients that have some of the better or more well-compensating insurance patterns. This is not right, but I believe that it is an unfortunate reality. Now, it is true, however, that states that have expanded Medicaid coverage have been able to show evidence of reducing cancer disparities through more broadly available Medicaid coverage. But Medicaid coverage, unfortunately, doesn't completely eliminate disparities, and we do still see differences. So the healthcare provider community does also need to assume some responsibility for making sure that we work quite hard at community education, at delivering care equitably, at offering clinical trials opportunities. We have to assume responsibility for making sure that cancer care overall is delivered equitably to all our population.
Yeah, but Doc, I thank you for your presentation, but I am looking at from a human standpoint. If the healthcare system looks at human as being human and not looking at a color, because diseases don't have color. And I think if the healthcare industry to look at people as human beings and not as color, and treat them according to their disease process, and just don't look at what the color, just treat them. Whatever you have for the next, for Joe is good for Tom. Whatever is good for Mary is good for Alice. Okay, so I all this thing would have been done away with hadn't been for this foolishness of, this color. And I'm actually sick of it.
Yeah. I don't think anybody could have said it better than you just did. Very true.
Thank you. I think unfortunately we're running just out of time. I see it's 12:01. So I'm going to open up the polling. If you could fill that out, that would be amazing. It's not necessary, it's anonymous, just to get a sense of where you are accessing this presentation from and how helpful you perceive the presentation to be. So if you could fill that out, that'd be great. And if there are any more questions last minute, feel free to ask them, or feel free to email me and I can pass them along to Dr. Newman if she's all right with that. I'll just put my email in the chat. And we can also refer you to any additional resources that we have. So that is my email right there in the chat if anyone has additional questions. And thank you so much again, Dr. Newman, for answering all of these and being with us today.
Absolutely. Thank you so much, Dr. Phillips and Allegra. It's great working with you today.
Oh, thank you
Thank
so
you.
very much. And just keep doing what you're doing. It's so deeply appreciated on an international basis. So thank you.
Thank you.
So
And have a
much.
good week, everybody.
You too.
Bye, have a great week.
Thank you very much, Doc. Very good.
Thank you. Thank you.
Okay. Thank you, everyone.
Thank you, Allegra. It was a great presentation.